Good afternoon again, and welcome everyone to another Supporting Client Health and Wellness class. My name is Melly Camarena. I'm an RN and work out of the Chico office. It's my pleasure to introduce Katie, who's here with us today. She's also another RN for the Regional Center and works out of the writing office.
Good afternoon.
Thanks, Katie. It's so nice, as always, to have all of you here today. We hold these classes every month with different topics. Sometimes we have guest speakers, as some of you know, and if you're new to us today, welcome. Today, we're going to focus a little bit more on just understanding and managing pain in individuals with developmental disabilities. So we'll go over a basic introduction, some basic, how pain is experienced and expressed differently. And then towards the end of the presentation, we'll talk about some different pain assessment tools that might be helpful for the individuals that we serve, as well as exploring pain management strategies. So we'll go ahead and start with, the definition of pain. The International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we all know this. Most of us have I'm sure have experienced some type of unpleasant sensory or emotional experience connected to pain, but it's very complex. No two people feel pain the same way, even if the reasons for the pain are alike. It's a highly personal experience, and a person's report of their own pain is the best measure, which we'll talk about later on how there can be complications to that, right? It's an evolutionary response to perceived or actual danger that serves as the body's warning system. It's complex, it's subjective, it's constructed by both our brain and our body working in conjunction. There's different sensations. It could be mild, it could be severe. There's prickling, tingling, stinging, burning, electric sensations. But it is one of the most important signals our body gives us to help us survive. It can alert us to harmful changes in the body, like if it's cancer, or help us learn to avoid something harmful, right? Like touching a hot stove. It's important in that way. So in some forms, it can keep us safe. But as we'll talk about later on in the presentation, there are, sometimes pain exists or continues without any known cause or benefit, known as chronic pain. And so we'll briefly discuss some of the challenges with that, as it can affect all aspects of daily life. So I'm going to show this quick video because I think it does a better job of reviewing the basics of pain. If I can get to it. Hopefully you are able to hear it. Let me know if you cannot. And we cannot hear it. It's okay, because we can continue with give me a second. We'll try one more thing, and if not, we'll just continue on. It was just a really, I thought it was a neat presentation, and I can always send it as a link, just showing some of the of how we may experience pain, but it's all right. We'll continue with the presentation. So with pain, we have receptors that kind of connects that pain sensation when something happens, that travel up our spinal cord to the brain. In the brain, it kind of helps process what it is we're feeling. And there's a combination of things that happen in the brain area, right? There's one area that's more connected to the emotional state to it, and then the area that's helps detect and lets us know, where in the body those signals are coming from. So in some ways it can be overly simplified, but it's very complex, like has different parts of our brain kind of working to help process all this different information. It can be categorized in different categories. We have the most common acute versus chronic. When we talk about acute, that's usually when something, pain starts suddenly and ends when it's cause is treated or healed, right? That feeling of acute pain is usually sharp because it tends to act as a warning signal about a threat to the body from either like an injury, disease, overuse, or other environmental stress. And some examples of when we reference acute pain, it can be like a strained muscle, a broken bone, we've had dental work, surgery, childbirth, infection, or burns. And often it's accompanied by observable signs, objective signs of pain. So you might see like increased heart rate, blood pressure, nonverbal signs and symptoms such as like a facial expression, tense muscles, versus with chronic pain, that's pain that is persistent and recurrent. And some websites or reputable resources might define it as pain that lasts longer than 3 months, anywhere from 3 to 6 months, or the expected healing time. In some cases, it could just be that an acute pain condition might persist and then it becomes chronic. Or, it could be chronic pain happens for just no known reason. And then some might experience, one or more chronic conditions or chronic acute pain at the same time. When pain persists in these situations, it doesn't serve a real useful purpose and may dramatically decrease the quality of life and function. Some of the more observable or behavioral signs that we might see with someone with chronic pain might develop into like anxiousness or depression, right? If it's not cured and they can't, find relief from it, it can lead to that. And then some examples might be like arthritis that's not being managed, or fibromyalgia. Nociceptive pain, that's what describes pain that is caused by like tissue damage or inflammation. The sensation can be sharp, pricking, dull, aching. It just really depends on what caused the damage or the inflammation. Some examples might be like an infection, broken bone, osteoarthritis. So this is just more like honing in on describing where the pain is coming from. So with somatic pain, usually the origin comes from like skin, muscles, bones, and joints. It's well localized. It can be easily pinpointed. It's often described as like a sharp, aching, throbbing. It can be aggravated by movement or pressure. So like I mentioned, a paper cut, a strain, bone pain from a fracture, anything that causes, inflammation or pressure. With visceral pain, the origin is from internal organs and tissues, so like the abdomen, the chest, the pelvis. Sometimes it's vague and poorly localized. You can't always pinpoint where it's coming from. It can be deep, squeezing, or cramping. And then it might be, you see it on the slide, be referred to other areas of the body, also known as referred pain, which is pain felt in a different location. So some examples: irritable bowel syndrome, angina. With angina, sometimes there's something going on with the heart, but people might feel it like on, their shoulder or the left arm. It's just pain that kind of radiates. Menstrual pain is another example. And then another category would be neuropathic pain. So that describes pain that is caused by like nerve damage due to an injury or disease. This pain sensation can be described as burning, tingling, shooting, or like electric shocks. And some examples might be, diabetic neuropathy, shingles, or sciatica. There's another category, it's not listed on here, it's nociplastic pain. Sometimes, you might hear that, and that describes pain that is caused by changes in how the nervous system processes pain. So the changes that cause this type of pain are not linked with a clear injury or like tissue damage, inflammation, or disease. So the sensations related to this can vary widely. And there's some connection with like neuropathic pain. It could be fibromyalgia or irritable bowel syndrome as well. But it's just another terminology that is used. Go to the next slide. Pain and the immune system. So the immune system helps protect the body from outside invaders, right? Like it protects against bacteria, viruses to avoid a potential infection. And one way the immune system provides protection is through inflammation. So inflammation is a reaction that happens when tissues are injured, and damaged cells release chemicals that cause swelling and attract immune cells to come and like essentially eat the dead or damaged cells. This process helps with healing. As you can see in this picture, it's a sample of, accidentally getting a thorn that's kind of protruding through the skin. Right on the left side, you see the injury. On the right side, you see all the inflammation and swelling that's happening. In some cases, though, the immune system is overprotective, and inflammation can last longer than expected healing time. And this overprotection can backfire and contribute to more and longer lasting pain. Another way that, that this can happen is, autoimmunity, which happens when the body's immune system attacks healthy cells. So like some of this autoimmune conditions we'll talk about later on with like rheumatology and all of that can cause chronic inflammation and pain. Our endocrine system is also really important. It's responsible for making hormones, which are a type of chemical messenger that carries instructions throughout our body. There's stress-related hormones like cortisol and adrenaline made in the adrenal glands that can send messages that make the feeling of pain more intense or less intense. This is partly why finding helpful ways of coping with stress can help lower pain intensity. And then, there's a lot of research that shows that chronic pain may lead to changes in the way the endocrine system functions over time. So how does pain affect us? There's still a lot to learn about it and how and why people feel pain in different ways. Acute pain with an obvious cause, so like an infection or a broken bone, for example, is much better understood, right? Because there's a clear cause. We know what's causing the pain. But chronic pain can be more complex. There's a lot of factors that play into this and the changes in the body. It could be like the mind, a person's experience with others, along with the conditions in their environment, all contribute to our own individual experience of pain. So for this reason, pain is known as a biopsychosocial experience. There's other biological factors associated with the pain. So like our brain function, our genetics, psychological factors are things like our mood and stress. Social factors include things like having or not having a support system or experiencing biased care. Each set of factors affect and impacts one another. Therefore, treatment for pain is both complex and individual. So a patient's self-report of pain must be the primary source of assessment whenever possible. Their acceptable level of pain must guide treatment. And I'm sure all of you are thinking, well, I've worked with individuals where this is not an option. If they're nonverbal, how are they going to tell us? So we'll talk a little bit more about the complexities around that. But in general, when it comes to a pain assessment, it's, what they say it is. If the patient is unable to self-report, then assessment strategies should include observable behaviors and physiological measures, so like the heart rate and blood pressure. when we're classifying pain, it's important that we know how to define, or like helping an individual, or if it's for you yourself and you want to, be able to provide a better picture for the provider. It's important to be able to, participate in that conversation, determining the context, history of the present illness, and type of pain. So underlying etiology refers to the source of the experienced pain, if there is one, where it's located, the duration, how long has the pain lasted, and then intensity refers to degree or level of the pain experience. And so, and all of this is, as providers are going to be looking into that and asking all these questions. If you're, an individual's, at the doctor's office and having these discussions with them, but it's good to have kind of a good assessment if you're assisting an individual. So, again, just initial pain assessment, location, intensity, sensory quality, alleviate, like what makes it better, what makes it worse. And the importance of pain reassessment, is a big one as well. So this can be for either someone that you're supporting at home, at program, or something to look at if someone's hospitalized, right? If someone is in pain, we should be assisting and reassessing it. If they're in a hospital setting and they're experiencing severe pain and they're giving IV medication for it, we should be working with providers and ensuring that they're being reassessed. So if it's with IV, within 15 minutes of administration. Versus if, let's say, someone's at home and it's someone who has been able to and is capable of expressing pain and they might need some Tylenol, we should always be assisting with reassessment. If they're given something, by mouth, coming back, checking in with them again, maybe like an hour later to see how effective it is. So I just have a quick, it's a little snapshot of like a PRN medication record, right? If you're someone who works in a home, whether it's SLS or a licensed facility, and you are responsible for keeping track of MARS, there's always a section on medications that are prescribed as needed. So it's always good to be able to document what was given and reporting back whether that was effective or not. So back to, the discussion of assisting an individual who is experiencing pain. What are some of the things that providers use to diagnose it and treat it? So as we know, pain is a subjective experience, meaning only the person experiencing pain can describe how much they feel and how it impacts their life. Research efforts are ongoing to find biological markers that can really help doctors diagnose why a person is experiencing pain. But after learning their pain history and medical concerns, a healthcare provider can conduct various like physical exams, clinical assessments, and order diagnostic tests and imaging to diagnose or rule out condition. So anything like a physical and neurological exam, right, are usually one of the first steps in diagnosing pain. They might test movement, reflexes, sensation, balance, coordination. A part of the physical exam might also detect areas of inflammation or joint or swelling, or even poor circulation. There's lab tests that can be ordered, right? Blood, urine, if someone's, especially if they're like nonverbal, but we know there's something that's bothering them, a simple urine test might be able to rule out whether it's a UTI. There's lab work that measure inflammatory markers that can kind of guide the provider in trying to figure out, is it inflammation? Is there something going on internally that's causing the pain? Problems with the nutrition or hormones or other conditions. There's imaging, right? Like an MRI or a CT scan or an ultrasound that can provide a look inside the body's structures and tissues. If it's let's say something gastric going on or digestive, they can do endoscopy or a colonoscopy if we think it's something with the bowels. So there's a lot, those are all very helpful in trying to figure out what's going on. And the biggest thing is assuming pain is present. Although self-report is often, the recommended approach, right, for assessing pain, it relies on that expressive communication abilities and cognitive skills to understand and self-reflect. And these are abilities that may be limited in some of the clients that we serve. So if there's an injury that's present that we're aware of, or the nature of a procedure, the patient would be assumed to have pain. A good example is, and I'm sure a lot of you on here, especially those who have worked with our population for a while, I'm sure have had these experiences and they're really negative. But we had an individual last year with Down syndrome who needed to have a G-tube placed, right, in the hospital. Within like 24 hours, someone with a G-tube, like that's a surgical procedure. I'm sure it's very painful. But because this individual was nonverbal, no one thought to give them any sort of pain medication after for post-recovery. Luckily, she had a really good advocates that could be there with her and identify that she hadn't been given anything. And the response back was, well, she wasn't grimacing, she didn't look like there anything was going on, so they just didn't give her anything. But, and back to the statement, assume pain is present. If we know, because of the nature of the procedure, we know it's going to be painful recovering, we need to assume the same for some of our individuals who are not able to vocalize that. And that's why your role is so important when it comes to advocacy. And we know there's a lot of challenges, right? Individuals with developmental disabilities or intellectual disabilities do suffer from health problems, and it's actually at a higher rate. There's some studies that show like 2.5 times higher than that of the neurotypical population. Those diagnosed at severe or profound levels of ID are more likely to have multiple complex medical problems, which may co-occur with communication difficulties. These disabling conditions really necessitate painful medical procedures, medical interventions, treatments, finding ways to overcome these obstacles in the assessment of pain may result in more timely and effective treatment of pain, not just for them, but also for just the populations that may not be able to verbally communicate pain. And we know there's a lot of challenges. Sometimes there's difficulty in discriminating between pain and other symptoms. Some behavioral expressions might be difficult to differentiate from other conditions, such as like anxiety, depressions, or just emotions. And some providers may inadvertently attribute the signs and symptoms of pain to the intellectual disability, even though, it may not be related at all. So we know that many of our individuals may exhibit just typical pain behaviors outside of anything. So like might have some self-injury, moaning, or facial expressions that we know can make it challenging to discriminate between pain or something else. So we know it's not always easy to identify. I think the other thing too, kind of going back to my example, is that sometimes there's incorrect beliefs regarding pain and sensitivity or indifference, leading to like underestimation as well as under treatment of pain. So there's, these are just kind of some of the challenges that they face, right? Some of our clients are at risk of developing like drug-related side effects, right? If they are given something, there's always that concern of, will there be other side effects? Because they might be on all these other medications and they might interact. So, but I think from just a lot of the studies and research that has been done in general, individuals with intellectual disability are unfortunately sometimes given fewer pain meds compared to the cognitively intact populations when it comes to just a general overview. There was a study. It was hard to find a lot of good like data as far as studies on pain prevalence and especially in the ID and DD population. But there was one research that investigated and examined the duration, frequency, location, and intensity of pain, as well as the occurrence of pain during daily activities. And this is specific to like CP, cerebral palsy, and ID. And what they found, that pain was a substantial problem for most participants. Chronic pain, so like I mentioned earlier, pain that persists for a minimum of 3 months was reported in 67% of these participants in the study, while 53% experienced moderate to severe pain almost every day. Most complaints were reported as back pain at 63% and lower extremity pain at 66%. Upper extremity pain was experienced for a mean of 7.5 years, while hip or buttocks pain had a duration of up to 20 years. There was another study who assessed pain in about like 94 youngsters aged like 3 to 18 with various levels of ID, ranging from moderate to profound. In this study, 73 participants, so 78%, were reported as suffering from pain at least once, while 35 to 52, so it's kind of like that range, had pain on a weekly basis. And the most common problems were musculoskeletal or gastrointestinal problems, which caused on average about 9 weekly hours of pain. In people with severe to profound ID, who usually and sometimes lack some of those, communication abilities, there's a greater likelihood of experiencing chronic pain in the long term. So kind of taking these reports together, it really does suggest that individuals with ID at all ages are suffering from more than their neurotypical peers. And, there's obviously still a lot to study and review, but really what it comes down to is appropriate pain assessment and diagnosis are always going to be that initial and crucial steps to improving pain management. So I wanted to kind of hone in on those two categories that they talked about, like musculoskeletal and GI, and why those were kind of like the two more common areas where individuals experience pain. And I think some of these might be kind of obvious, but I feel like it's good to kind of run down through it, just because there are a lot of factors that increase the risk of both acute and chronic pain, right? So they might have an increased risk of accidental injury. Some of individuals have reduced involvement in health decision-making, more physical comorbidities, greater musculoskeletal disorders. We might run into, low levels of physical activity, reduced use of pain management services. And then there's also just, the normal age-related changes associated with, life expectancy. As I mentioned from that study, the presence of like cerebral palsy or other physical disability are common among people with chronic pain. So with cerebral palsy, it often leads to various musculoskeletal problems due to like neurological damage that affects our like muscle tone, movement, joint function. These issues can include contractures, so shortening of the muscles, abnormal bone growth, and joint instability that impacts the function, and also high risk of osteoporosis and early osteoarthritis. As we know, they might be associated with some motor impairments, increased muscle tone, spasticity, and spasm can really significantly cause some discomfort. And then sometimes treatment can involve invasive surgical procedures and other painful injections or interventions, right? So I think when it talks about musculoskeletal, there's kind of different components, but those, were some of the things that were mentioned. When it comes to gastrointestinal pain, GI dysfunction is, particularly common in some of the individuals we serve, right? Those with autism, there's certain syndromes like Rett syndrome, Down syndrome, cerebral palsy again. GI conditions, excuse me, can include gut malformations that are sometimes present at birth. There's some conditions called like pyloric stenosis, which is when the muscles between the stomach and small intestine are thickened and narrowed, making it difficult for food to pass in the intestine. There could be other functional issues such as like feeding problems or GERD, gastroesophageal reflux disease. That's a big one, and it's very common. And that is what refers to the backflow of acidic or non-acidic stomach contents that travel back into the esophagus. And that essentially you have stomach contents that are going up. Normally we have a band of muscles at the junction of the stomach and the esophagus that act as a barrier to prevent the reflux of stomach contents to go up. But if that barrier is relaxed for any reason or just compromised, the reflux can occur. And it can be very painful. I'm sure most of us have experienced that, for whatever reason, and we know it's not very comfortable. So if we have someone who has this chronically, it can be, painful and also lead to really serious complications like inflammation or other complications from recurrent GERD. Other conditions that might cause GI pain could be like delayed gastric emptying, bloating, irritable bowel symptoms, constipation, which is a big one. I'll spend a few minutes talking about that a little bit more. Stool impaction, all things to consider because we do see our clients have a high risk of having these other health conditions. So it's always good to, rule some of those things out if we ever have someone who is experiencing pain and can't tell us where it's coming from. With constipation, it's a common and serious problem for our individuals. Up to 40% of the population may experience constipation, and it can be significantly more problematic than in the general population. And it can lead to complications like impaction, obstruction, and if it's not treated, people can die from it. So it can be very serious. For the same reasons that affects, other body systems, they might have neuromuscular problems that affect the bowel function, the mobility. There's medications that are commonly prescribed that can have these constipation as a side effect. Diet, all influence it, and then communication barriers, right? Difficulty communicating, discomfort, or pain can really delay the diagnosis and treatment. And this is another complication from constipation, fecal impaction. It occurs when something prevents the contents of the intestines from passing normally through the digestive tract. It can cause a blockage inside or outside of the intestine. And it could be just from constipation, or there could be something else going on, a tumor or, swelling of the intestine. But whatever it is, it's causing that blockage and can lead to some really serious complications. And so the reason I am sharing this again, I know the topic for today was about pain, but we do see the issues of constipation and bowel impaction come up very frequently. And it's very challenging, especially when our individuals are not able to tell us what's going on. So we've had previous trainings on cerebral palsy. We've done trainings on bowel health and bowel obstructions. Most of those are recorded on the YouTube page. You guys are always welcome to go back and kind of review those in more detail. But we always do like to remind about these conditions because it's all related. So I'll kind of go through these fairly quickly, but what do? We've talked about a lot about, pain and some of the complexities in the population that we serve and the inability to not always be able to assess it correctly, especially if they're not able to tell us. There are a lot of tools and assessment tools out there that can be used. One of them, I'll see if I can pull it up. There's the pain assessment in advanced dementia. That is one example. I'll just pull it up here really quick because this one's kind of neat. It kind of looks at the items on the far left. It's looking at, their breathing. Are they having labored breathing, short period of hyperventilation or noisy breathing? Are they moaning, groaning? Are they crying? That's something else to look at in someone who might have, dementia or not able to verbalize what's going on. Facial expressions, body language. Are they relaxed? Are they tensed? Are they rigid? Are they able to be distracted or are they not? So it's just a quick tool. You can look at those 5 items. You tally it, and on the far right, and then on the bottom it tells you, total scores from 0 to 10. A higher score indicates more severe pain. So just a quick and easy tool that can be used in assessing pain. There's another tool here. This one's a little bit more comprehensive. Pain assessment and impaired cognition. It's looking at facial expressions, body movements. Are they guarding? Are they rubbing? Is there some restlessness? Vocalization. Are they using words like ouch, ow? Are they shouting? Are they groaning, mumbling, complaining? So just another example here. And then so those were the 2. Obviously, family and caregiver input is super important and really important with, for advocacy. If there's a doctor's appointments or if they're hospitalized for whatever reason, always providing that input to anyone who's going to be providing care. What's normal? What's their baseline? What's not normal? So that it gives them an idea of, what to look for. This is another tool, face, legs, activity, cry, consolability. It looks like, their facial expression, their legs, are they restless, tense, kicking? If they're able to, activity, are they squirming? Are they lying quietly, crying, and consolability? And again, it's a quick scale on the bottom. It gives you, each category scored on the 0 to 2 scale, and a total score of 0 to 10. So if someone scores between 1 and 3, mild discomfort, 46, moderate pain, or 7 to 10, severe discomfort or pain. And some of these tools are kind of have similar items that they're looking for. These are just examples that can be used. Here's a checklist of nonverbal pain indicators. We're looking, again, same thing, vocal complaints, facial expressions, restlessness, rubbing, another tool to look at any pain. So, pain management strategies. I'm sure a lot of us have used some of these techniques. What can we do if it's something, not serious? It's always good, looking at comfort positioning, anything with sensory regulation techniques, distraction, guided imagery, heat and cold, massages, acupuncture. We'll talk about that a little bit more. And then we have medications. There's different medications. Non-opioid pain relievers, that's going to be like your Tylenol, your Motrin. So with acetaminophen or Tylenol, that's going to be effective for some of that mild to moderate pain. Obviously, it's also used for like fever or muscle aches. It's generally considered safe when taken as directed. We always want to make sure that there's not excessive dosing, because that can liver damage. Some non-steroidal anti-inflammatory drugs. Those are like your Advil or Motrin that reduce pain, inflammation, and fever. While generally safe for short-term use, it can also increase, issues with like stomach ulcers with long-term or high-dose use. There's also topical pain relievers. Those are the ones that are, applied directly to the skin to relieve pain from muscle aches or arthritis. Anti-anxiety medication sometimes can be prescribed, and can be used to manage like muscle spasms associated with severe pain. In some cases, you've seen like anticonvulsants can help relieve some of the nerve pain that reduces pain signals from damaged nerves. Some antidepressants can also help with nerve pain after, at a lower dose, obviously, than those used to treat depression. On the far right, you have your opioids or narcotics. Those are the strong pain relievers that work by altering the brain's perception of pain. They can be effective, for moderate to severe pain, but obviously carry a risk of addiction, overdose, and other side effects. So some examples would be like codeine, morphine. Other medications that can be used for pain, local anesthetics, that's used to numb a specific area of the body. Steroids, or certain injections that can reduce inflammation and provide temporary pain relief. So for the purpose of time, we're not going to go into all of these directly, but just a general overview of the different medications. And then just remember, because just talked about constipation, keeping in mind that there's a lot of these same medications that you saw on the other list can also cause constipation. So recognizing some of these as commonly prescribed. So it's important to have a plan in place to prevent constipation should an individual be started on some of the medications that were just mentioned. So you have like antidepressants that was mentioned. Obviously it's in a lower dose, but can be problematic. Some of the seizure medications mentioned, strong pain meds, so the opioids, that can cause constipation. So if anyone's ever placed on one, we always want to make sure that there's a good bowel protocol in place. Antacids is also another one to keep. Obviously, it's not going to, some people might need it for like GERD or their acid reflux. Certain antacids can cause some constipation. So just keeping that in mind. And the reason why is many of the medications on this list also have anticholinergic side effects, which is medications that can block the effects of a chemical that helps the muscles move. So that chemical is called acetylcholine, and those receptors are located throughout the body, including our intestinal tract. So if these medications are taken, to help alleviate pain, there's also a chance that it's going to cause less movement in the gut, which can lead to constipation. So just keeping that in mind. Back to medications, what do we look at with chronic versus acute? Chronic pain. So if we're looking at pain that just doesn't subside, you've had it more than 3 months, a lot of the times they'll try whatever's under the acute pain medications first. And if that doesn't work, they might look into an anti-seizure medication, an antidepressant, and see, if some of those are more successful. And then when all else fails and benefits outweigh the risks, opioids might be considered. And then with acute pain, most often it's going to be treated with, some anti-inflammatory, some Tylenol, splinting, positioning changes. If it's severe enough, they might add some opioids to it. Physical therapy might be another option for someone, especially if they've had chronic pain. They're going to help people recover from injury or surgery. They might use massage, stretching, heat, ice, exercise to help ease the pain and increase mobility. And they do really play a crucial role in pain management by addressing some of the underlying causes of pain. Can help improve function and potentially reducing the need for medications, especially like opioids, that also has those side effects. So, their physical therapists are going to help kind of identify the source of pain, whether it's like a muscle imbalance, some stiffness, poor posture, and they're going to develop that personalized treatment plans to address these issues. Obviously, this isn't going to be, a recommendation for everyone. There's going to be certain situations where it's not appropriate. If someone's not able to cognitively participate, obviously wouldn't be recommended, but just keep in mind physical therapy can also be a good technique to help with pain management. There's also a lot of different types of specialists. Keep in mind if you're ever working with someone or for yourself, that there's other avenues to consider, especially if there is chronic pain that just doesn't seem to resolve. And, sometimes they might be for treating pain that doesn't have a clear cause, right? So it might be a pain medicine specialist. It's always good. Obviously, referrals would always need to come with primary. So these are discussions that would need to happen with primary care provider. There's orthopedic specialists. So they treat like injuries and diseases that affect the musculoskeletal system. So like bones, joints, ligaments, tendons, muscles. There's some specialists that specialize like in certain parts of the body, like the hips, knees, and shoulders. But once they diagnose the injury or disorder, they'll create a treatment plan that may or may not, include medicine, or might recommend exercise, or again, refer back to physical therapy. There's osteopathic doctors. They're similar to medical doctors. They, went to medical school, but they have a DO after their names instead of MD. And they get extra training in the musculoskeletal system, which includes nerves, muscles, and bones. Rheumatologists, they treat rheumatic diseases, arthritis, osteoarthritis, rheumatoid arthritis, gout, tendonitis, all these conditions that can cause pain, swelling, and stiffness. And treatments might include medicine, some anti-inflammatory medications, pain blocking injections. So always good to, consider that if it's, to treat some of those other conditions. A physiatrist or rehab physician. They're also known as a physical medicine and rehab doctor, PM&R. They treat, injuries and conditions that affect how you move. They diagnose and treat pain related to nerves, muscles, and bones, including like carpal tunnel, neck and back pain, sports and work injuries, herniated disc, arthritis, concussions, post-surgery pain. we might see a lot of the times, like, cerebral palsy, if there's an individual who might benefit from, specialty, that's usually who is recommended they be referred to. A lot of the times when they're kiddos and they're, part of like the California Children's Services Program and are getting services, a lot of those providers are PM&R doctors because that's kind of their specialty. So if there's ever any need for any of this, talking to the primary care doctor for referrals. And I think in the previous one, I talked about acupuncturists. That might be a recommendation. Massage therapy might be, that was, more for non-pharmacological options. There's also, I'll kind of go through this fast just because we're running down out of time here, but different procedures and devices that might be recommended by some of the specialists to help alleviate this pain. So again, if we ever are working with an individual whose chronic pain is not resolving, it's good to help advocate and talk to a primary to get a referral to a specialist who might be able to hone in and provide more targeted therapy for them. So this is just a quick example, transcutaneous electrical nerve stimulation that delivers low electrical pulses through the skin to the nerve fibers to help relieve pain for a short time. Sometimes you'll see it too, like if you've ever had physical therapy and they've worked with you, sometimes they'll end the session with some electrical nerve stimulation around the area that's causing problems, and and it does help with some of that pain management. So just as a summary, the importance of being proactive, whether you're working with an individual home or a program and you see that things are off, sometimes with several behavioral changes, it's going to be a form of them communicating, especially if it's someone who's nonverbal. Any changes in the routine, increased sensitivity, all of these, it's always good to keep in the back of your head, like, are these potential signs of something? Is it pain or something else going on, especially in those who cannot tell us that something's hurting. I always like to throw in the health passport here. I know we've talked about it if you've attended some of our other trainings, but health passport, super, super important. These are personal profiles that document an individual's, who they are, especially if they are hospitalized and they don't have any family or caregivers that are able to stay with them throughout the hospitalization. If you are in any capacity to help assist an individual complete one, like, please do. This is just the first page of the whole passport, but there is a section that talks about pain behaviors. And that's important to help communicate with caregivers so that they can recognize what's normal or what isn't. Utilizing pain assessment tools, I mentioned some. Some of them are specifically designed for individuals, with developmental disabilities. Always, anyone can use those if you see like there's something wrong and they're not able to tell you. It's helpful to kind of look at that and just do a quick assessment. Talking to primary, obviously, anytime there's anything wrong. Helping them advocate if they're hospitalized. Again, we can't assume that they're getting everything that they need, or that the caregivers, know what they want. It's always good to, if they're having something going on, asking those questions. Are they on anything? What do they benefit from being something, so that they are comfortable? So thank you. I know kind of ran through that pretty quickly, but thank you all for sticking around. I have one final announcement before I just open it up in case anyone has comments or questions or anything they want to share. We do have, kind of switching gears, tomorrow, the regional center is hosting a safety and emergency preparedness fair. It's at the Red Bluff Community Center. It's tomorrow from 10 to 3. I would encourage you, if you have, whether you're a day program or, an administrator at a facility, if you can and are able to, we encourage you all to, bring clients encourage them to attend. There's various booths with a lot of information. A lot of vendors from the community are going to be there. It's going to be a good time. So just wanted to throw that out there. I know it's tomorrow, but hopefully if you don't plan on going, you make some time to stop by and see some of us there. With that, I just thank you all for attending and participating. If you have any other questions or comments, stick around for a couple more minutes. You're welcome to unmute yourself or use a chat box. And if you haven't signed in, please do so that we take attendance and get you a CEU certificate. Great. Thank you, everyone.